So, good evening, all our members of esteemed members from Maharashtra Ophthalmological Society, and those of us who are joining us uh, from all the corners of India, from All India Ophthalmological Society. As the chairperson of the scientific committee, I am Dr. Vardhaman Kankriya, and I welcome you all to this very exciting and probably one of the most, let's say, targeted topics in current times is how to start myopia clinic and how to arrest myopia progression. Friends, we all know that we are actually going through what can be called as the myopia boom. And this myopia boom is not related or restricted to Eastern Asia, but it is now going around the world. We all see that more and more children are coming with myopia incidence as well as progression as well. This has truly become a public health issue all around the world. And of course, currently, as many of you must be knowing, that many researchers have shown that by 2050, close to 50% of world's population can become myopic. You would ask, what is the issue of being myopic? They just have to use glasses. But the studies have also shown that as the myopia progresses, your other comorbidities of the eye, such as incidence of cataract, glaucoma, and retinal issues, they increase many folds as well. And that's why it is very crucial at this regard to understand if we could actually stop or at least slow down the myopia progression of this generation to give them much better vision and vision quality and quantity both in the future. Friends, there have been a lot of newer advancements in and research in newer methods of myopia control, and we are going to dwell into nuances of each one of them. We are extremely lucky to have wide array of speakers who are considered to be myopia experts nationally. They have joined us as national faculty, and we are also very lucky to have our own set of MOS faculty who are going to take us through this very exciting webinar. Before we go further, I would like to now invite our guiding force, the strongest support, Dr. Santosh Agarwal sir, who is our honorable president, who has always led from the front and always guided us in all our ventures throughout the year. So over to you, sir, for your welcome address.
Thank you, Dr. Vardhaman, for your kind words. So, guys, respected seniors, teachers, and my dear friends, very good evening to everyone. At the outset, I thank Dr. Vardhaman, Aditi, and entire scientific committee of MOS for curating this distinguished webinar on such a vibrant topic, that is myopia. As we know, myopia has become an emerging issue nowadays. Trendy lifestyle, escalating screen time, especially in a young age, has forced this problem to a great extent. Today, we are going to discuss and explore the risk factors, awareness among population, and the solution to the problem. And also, very vibrant topic, that is how to start a myopia clinic, which is very new to all of us, which would be an eye opener for all of us. I express my heartfelt gratitude towards the esteemed speakers and panelists who are going to enlighten us, which would certainly be useful in our day-to-day practice. I am also grateful to Dr. Roshni Desai ma'am, who is going to moderate today's webinar. I am sure we would fetch many pearls from today's discussion. MOS is always MOS always strive for such fruitful webinars for our colleagues. Last but not the least, I am thankful to my MOS team, my secretary, Dr. Atul Kadane, treasurer, Dr. Mandar Paranzape, Entot team, and the august audience as well. Thank you very much for your patient listening. Thank you.
Thank you very much, sir, for encouraging words. And we also thank the support from the entire MOS team, Dr. Atulji, Dr. Mandar sir, Aditi, and everybody. So basically, friends, before we go further, now I would like to introduce a very good friend and who has been the main coordinator for this entire webinar, Dr. Roshni Desai. Dr. Roshni has been a gold medalist during her MS ophthalmology, and further on, she went on to do her pediatric ophthalmology at the prestigious Shankar Nethralaya. After which, she has come back to Mumbai and she has been working very closely and very passionately as a pediatric ophthalmologist. She has created awareness in variety of forums and has recently also started her own five senses multi-speciality clinic. In the last decade, she has done more than 2,000 surgeries, which is quite a significant experience. And she has worked on basically with NGOs and also variety of charitable institutions in Gujarat and in Maharashtra from time and again. So thank you again from MOS, Dr. Roshni, for all the efforts. And over to you to take this webinar to its fruitful discussion and further discourse. Thank you.
Thank you, Dr. Vardhaman. Thank you, Dr. Santosh. Actually, I was just thinking it's raining outside and schools have started. And again, because of the rains, the schools have shut. And what a miraculous coincidence that we are talking about myopia. I mean, both these things, rain outside, no sunlight, schools have started, academic pressure, it all just conspires for the myopia to progress. So it's the month of July, and we are sure by the next holidays, when the children will come for follow ups, their myopia would have progressed because of the environmental conditions they have been in this monsoon. Without stretching the introduction further, I'm really thankful to all the speakers. I mean, these speakers are not just experienced, but they are so passionate about this topic of myopia that most of them have gone and done research and pursuing PhD, like a doctorate over a doctor, for this topic of myopia. Means that there is so much that we are not aware of in the progression of myopia, because the lockdown showed us that yes, it did introduce myopia or progressed myopia in many children, but many didn't. So who are progressors, who are non-progressors? There are many questions which are yet to solve, and myopia remains a mystery. So I'm thankful to these esteemed speakers for agreeing to speak on this topic on such a short notice. And let us start. I have made a presentation like a PPT for just introducing these people because their CVs are so big. So let me share my screen, and we can start with our first speaker. Is my screen visible?
Yes, it's visible.
So our first speaker is Dr. Shruti. Thank you, Shruti, for agreeing to talk on this topic. Shruti is going to speak on physiology of myopia and the atom studies and what are the practical implications. Shruti has done her long-term pediatric ophthalmology fellowship from Shankar Netralaya, Chennai, and now she is a consultant at MNI Hospital in Chennai. She's a joint editor in the TNOA journal and reviewer of the journals mentioned here. Shruti is currently pursuing her PhD in the topic of myopia, and I'm sure she has way more insight than we clinicians, because she is dealing with many people who are doing, in-depth research in the pathogenesis of myopia progression. Over to you, Shruti.
Thank you so much, Roshni. Thank you, Dr. Santosh and Dr. Vardhaman, for having me here, and to MOS for this opportunity. So I would just quickly try to share my screen. Are you able to see my screen?
Yes.
Okay. So today I've been given two tasks, which I will try to figure out in two parts. And the first one is, of course, understanding why myopia happens and what is myopia, and then to talk a little bit about the practical implications of atropine. So myopia is not a disease that's born today or yesterday. It's been there from 350 BC. Aristotle was the first one to kind of talk about it. I'm just trying to see if I can go to the next one. So he found out that, people who had smaller eyeballs actually could see farther, and people who had protruding eyeballs could actually see closer objects better. And that was one of the first earliest reports of myopia. From then to 2024, I believe it has undergone a big metamorphosis. And then the disease now, as we see today, has undergone evolution. And we see this huge monster standing in front of us. So now we see this this is from the LVPI group. Dr. Pavan is here. This is a study he worked on. And you can see that by 2050, Indian children are postulated to be myopic almost by 50%. And not just that, I would like you to draw your attention to another table in that same study. And you can see that this is the current one. And you can see by 2050, a huge chunk of the working population in India are going to be myopic. And these are the ones who are actually contributing to the socioeconomic development of the country. And they're going to be myopic. So again, this is a call to action for this, for waking up to the awareness of this disease and its management. So no longer are we going to have kids like this. We're going to have kids. We're going to be seeing more of these kids with glasses, and it's not like every child is special. More likely that every child is probably going to be myopic unless we take some action. So let me begin by how the interest started in myopia. There were two reasons. The one was the rapid increase in the incidence and the prevalence. And that is because the developed countries started focusing a lot on educational success. And the second reason is that there was a sudden discovery that myopia could be experimentally induced. And this was a very significant discovery, that myopia could be induced by either lid sutures or by diffusing goggles. And this led to huge amount of myopia research. Now, but to understand why myopia happens, it's important to understand the process of emmetropization. So when you look at this image in an emmetropic eye, the image falls on the retina exactly at the fovea, and a sharp image is formed. Thereby, there's no problem. But what happens when there are two specific conditions? One is defocus and the other is blur. Now, defocus and blur are two completely different mechanisms which can induce myopia. Optical defocus is something similar to placing a plus lens, creating a defocus that actually creates a kind of a blurry image on the retina, but that blur is actually a defocus. So this is something akin to an uncorrected refractive error. But what is a low pass filter or a blur? It is something like a media opacity, wherein it completely blurs out the image. Now, what is the difference between these two stimuli? The first stimuli actually is a closed loop, which means that at some point, as the eye grows to accommodate the clear image, there will be a clarity of that image. And once the image becomes clear, the eye will stop growing. Whereas what happens in this media opacity, the eye continues to grow thinking that at some point it will reach a clear image. However, because the problem is with the media opacity, it never reaches that stage. So the eye continues to grow. And this is what is called an open loop. Now, emmetropization must actually operate as a closed loop feedback system with a stimulatory and an inhibitory mechanism. And that is what we are trying to do in the second situation. Now, when we look at form deprivation eyes, there is clear evidence that there is scleral remodeling happening. Now, look at this interesting study where they studied the role of collagen remodeling in chick eyes with form deprivation. And you can see this loss of collagen slowly happening over from day 2 to day 21. So scleral remodeling is a real phenomenon that happens. Another important thing to note is that everything that happens is a local mechanism. There is no cortical control over this. And this was found when they found that transecting the optic nerve of chicks actually did not make a difference in the myopia progression. The myopia continued to progress in spite of the optic nerve being transected. So this again goes to show that the signal mechanism starts from the retina and then moves back to the sclera to cause the scleral remodeling. Again, another important thing to understand is the myopia fovea driven or is it peripheral retina driven? Now, it's what they have found out in monkeys when they have removed the fovea. If they've removed the fovea part and still given a defocus stimulus for myopia growth or a form deprivation stimulus, the myopia continued to progress. Again, it goes to show that it is not the fovea, but actually the peripheral retina that is actually playing an important role in myopia progression more than the fovea. So these are the concepts that we need to understand in myopia before we enter into the management strategies. So having understood a little bit about physiology, let's now move into atropine. And atropine, how does it work and where does it work and why does it work? Now, we know that there are several interventions which are going to be covered by a lot of experts today. And I'm going to be talking about atropine and its practical implications. Now, we do know that atropine primarily works by increasing dopamine. It increases they have found that in chicks who have form deprivation versus form deprivation plus atropine, they found that the dopamine levels are much higher in those chicks which have been given atropine as compared to only form deprivation. It goes to show that the dopamine levels definitely play a role in the mechanism of action of atropine. Again, they found in humans that there is an increased level of vitreous dopamine and dopac levels, again contributing to this mechanism. Another interesting mechanism that they found is that it inhibits inflammation through the downregulation of phosphoinositol pathways. Now, these are the two areas by which it stops the tissue remodeling. Now, let's look at a quick summary of the ATOM studies. Now, we know that this is the great table that all of us talk about. Now, this is the ATOM study, which talks about 60 months of follow-up, where they have the placebo group, where they had one 24-month follow-up and one myopia progress from minus 0.75 to 1.5. Now, this is what we call a typical progressive myope. Now, what are my recommendations to actually start a myopia control strategy such as atropine? The first thing is a child more than 4 or 5 years with documented myopic progression of more than 0.5 diopters in the preceding year. And this 0.5 diopter should be a cycloplegic refraction. It's important to be a cycloplegic refraction. Now, if you have this kind of a documentation, then it's important, then you can probably start these kids on daily dose of atropine for a period of 2 years. Now, at the end of every year, you can review them for their response. If the progression is within 0.5 diopters of year, this is what you call a good responder, and then you continue them for a period of 2 years. Now, if the response or the progression is more than 0.5 or 0.75 diopters per year in the second year, then you consider increasing the dosage, or you consider putting them on combination therapy or shifting them to another therapy. Now, here again, it's important the word second year. So whether they improve or not, it's important to put them on 1 year and then wait for the response. It's not good to jump at the 6th month itself, because some children take another 6 months. It takes about a year for the complete effect to start off. So what happened with this kid? We started the kid on 0.01% atropine, and you can see, lo and behold, the child beautifully stabilized and is currently stabilized as well. So that's a good success story. So yeah, we are happy, but not all cases may have a great response. So let's look at case scenario 2. This is again another 8-year-old kid. We started the kid on atropine when the child was -2, and then COVID pandemic hit. This was sometime before the COVID pandemic, and you can see that in spite of the child being on good compliance with atropine, the refractive error progressed, and this is what we call resistant myope, and that's probably because there was a lot of lifestyle factors also involved. Now, at this point, we need to understand that during the COVID, not just the refractive error in all children generally tended to be much more higher than those children who were pre-COVID. And also we see the difference in the outdoor activities had drastically reduced and the indoor time had drastically increased. So now, having put all of this together, it is always good to combine therapy in children who are resistant to one therapy. So there are two important studies, one from Kemak et al., Germany, and one from Huang et al., and they both showed that not just atropine, but DIMS plus atropine had actually a much better effect than one monotherapy alone. So combining therapies with diverse mechanisms of action actually creates an additive effect rather than a single effect. So here you see combination therapy has been tried with atropine both in DIMS, as per this study, which is the Huang et al. Study. You can see clearly that the DIMS plus atropine group had much lesser progression than the monotherapy group. You can also see that these are other studies where the orthokeratology has been combined with atropine and MiSight contact lenses have been combined with atropine. And both groups clearly show that there is a good effect with combination as compared with monotherapy alone. So this is a short case series where we had studied 10 of our kids who had combination therapy. This is a control group where we just followed the kids up with single vision for 1 year, and you can see they progressed by almost -1 diopter. Versus kids who were on low-dose atropine for 1 year, you can see that they had progressed by 0.74 diopters. And when they were put on combination therapy, you can see the combined effect of 0.25 diopters, which is much better. So, of course, the combining effect of this really plays a good role in cases who are resistant to monotherapy. So how did she fare? Of course, with the combination therapy, she kind of stabilized and did well. So yes, that was a close call, but then we kind of saved the situation. Now let's look at case number 3. This was a 14-year-old girl with a new onset.
I'm sorry to interrupt, but we have run out of time.
Okay.
So if you can just make it a little quick, because next speakers will also be speaking on glasses and combination therapy.
Okay, cool. So, so this is just about compliance. So like if you're at the end of 1 year, if your child is showing a progression, always look for compliance, ask for compliance, and look for pupillary dilatation. And that's a good way to see whether the child is compliant or not to the drops. So I'm just going to quickly skip through. This is case scenario 4, and this is after stopping, you see this rebound after 2 years of continuing and stopping. Why does that happen? That's probably because we do not taper and stop. It happens more in higher concentration, younger kids, parental myopia, and indoor lifestyle. So in these cases, I try to ask them to taper it over 3 months, thrice a week, twice a week, and once a week for each month, and then stop it. It really helps much better. So this happened, the child again stabilized. So again, a case saved. So the take-home message is it's an excellent choice in all of these situations. Combine when required and continue for at least 2 years, and taper and stop them whenever you decide to. Thank you so much for the opportunity.
Thank you, Shruti. Thank you so much for beautifully explaining the physiology of myopia. And we have our next speaker with us, Pawan Varkichela. Again, let me share my slide on introduction. We are really grateful to Pawan for accepting our invitation, because I see that he's the head and consultant optometrist at the Inform Myopia Center at the LVPI Eye Institute. And after finishing bachelor's, Pawan has done PhD from Queensland University of Technology and postdoctoral research at Singapore Eye Research. We are really eager to hear what you have to tell us about myopia.
Thanks, Dr. Roshni, for the kind introduction and inviting me to speak here. I will share my screen. Yeah, can you please confirm that you can hear me and see my screen?
Yes, we can, both. Thank you.
Great. Thank you so much. I note the time and will start directly to the point on the optical corrections for myopia. And want to highlight by indicating that I think we moved out from talking about mere correction, and we are clearly going and talking more about the controlling the progression of myopia, talking more about the reversal these days, and clearly want to highlight that it's beyond mere correction when we talk about myopia. Now, I think there are multiple ways to combat this problem. The epidemic that Shruti has nicely indicated took us through 1 out of 2 to have myopia. Everybody believes in their own protocol, but I think at large, be it in India or wherever in the world, we are worried about the complications that might occur because of the ocular stretching. And therefore, the agenda worldwide is to regulate the eyeball from growing, as you see in the image on the right of the screen. Given that myopia is multifactorial, there are multiple solutions out there, starting with environmental strategies, pharmacological strategies, and the optical strategies. And today, I will be concentrating on the spectacle and the contact lens options for myopia control. In the large context, I think it's important also to talk about the lifestyle modifications other than the optical and the pharmacological. So that I will just indicate that. And widely prescribed low-dose atropine, I am aware that the next speakers are talking about it. I also want to indicate that there are light therapies that are coming out, which might be the future for myopia control. Now, coming back to the context of my talk, which is on optical myopia control strategies, as you see on the screen, it starts with the bifocal or the progressive addition lenses. Now, bifocal or progressive addition lenses are meant to counteract the accommodation or to relax the accommodation. And these lenses work great when there is a bit of esophoria or when there is greater lag of accommodation. There is evidence out there, maybe it dates back to 20 years before, indicating that bifocal lenses actually work in myopia control. And I do prescribe in my practice as well. And we have seen good efficacy. Again, not everybody may benefit from bifocal, but if you see lag and maybe esophoria, I think these are the ones you might want to target for prescribing the bifocal lenses. When we talk about bifocal, people also get worried about the segment being very visible, the cosmesis coming into the picture, but that's where we can target the digital or no line bifocals. Now, I will be targeting more on the next generation myopia control lenses, which are believed to work by inducing the defocus in the periphery. When I say defocus, we are looking at inducing the myopic defocus in the periphery. Now, what are these types of myopia control strategies? Dates back to orthokeratology, very old practice of using sandbags on top of the eye to press the cornea, usually used for correcting the refractive error, but now we talk about myopia control as well. We have options in spectacles and in contact lens, both the extended wear and the daily wear as well. So when I said it is known to induce myopic defocus or known to counteract hyperopic defocus, I thought I will quickly run through a couple of slides indicating what is meant by myopic defocus. Refraction in the periphery, if it's much more in front compared to the center, as you see on the screen, it's relative peripheral myopia. It can be relative peripheral hyperopia as well. Compared to the central, the rays are much more focused beyond the retina, acting like a trigger stimulus for the eyeball to grow. Now, what is wrong if you prescribe a single vision, if you believe in hyperopic defocus theory? In uncorrected eye, seems like the peripheral rays will be much more hyperopic, as you see on the image there. The point P could be triggering. If you give single vision lens, everything is diverging. The entire image shell shifts back. Central rays are on the retina, great, we are very happy, ignoring the periphery of the eye. Now, these peripheral points can trigger for the eyeball to grow. So what is desired is center to be optimally corrected, and in the periphery, we want the rays to be much more in front of the retina. So that's where we say relative peripheral myopia acting like a stop signal. So what do we have now to counteract that or to induce myopic defocus? This is much more recent, the diffusion optics technology playing with the peripheral contrast. Then you have the very old MyoVision from Zeiss. Essilor has got Stellest. Hoya has got MyoSmart. Then we have MyoSafe. Multiple lenses are now made available in India. In contact lens, we have orthokeratology and multiple contact lens that can take care of center and the periphery of the eye. To talk about the peripheral defocus lenses that are first available in India, we have this MyoSmart from the Hoya. On x-axis, you are seeing the duration in months, and y-axis change in axial length. Largely, I want to indicate that over a period of 6 years, a study was conducted, and the efficacy is close to 60%. And if you go to the Stellest, again, the defocus lens in the center, it's clear, works on the philosophy of Hall technology, highly aspheric lenses technology. And this also shows about 64 to 70%. Again, I'm showing 12 months, but the recent results are out, which indicates good efficacy for 4 years as well. Now, this one I've showed much more recent one, the diffusion optics technology, playing with the contrast in the periphery of the eye. If you look at the control, 0.3 millimeter change in a period of 12 months in axial length. Whereas if you look at the diffusion optics technology lens, which shows only 0.15, which is again showing about 50% efficacy in controlling the eyeball from growing. Now, what do we have in the contact lens? There are multiple options that are available in contact lens as well. In terms of soft lens, this is center distance design. We talk about multifocal contact lens that can be prescribed for presbyopes. Same contact lens can be given, but it should be center distance. A multifocal contact lens can have center distance design or center near design. And we are concentrating on the center distance design, and the periphery it will be more and more plus, and you will see that it can take care of the peripheral defocus, as you see with different designs, concentric, aspheric, or multiple designs. MySight is one of the well-established contact lens, FDA approved, and it has got its own results for 6 years, indicating good outcomes. Seed is another company from Japan, also got multifocal contact lens, extended depth of focus contact lens as well. And orthokeratology I've already spoken about. There is enough evidence to say that these lenses actually work over a period of years. And this is the data from 2013. So, I mean, I've got 10-year-old data. So orthokeratology is there forever. And even before 10 years or 15 years, people are prescribing for myopia control. There is good efficacy. This is the FDA approved lens that I was talking about. My site, we do not have this in India yet. But again, if you look at somebody who's getting single vision lens versus my site, I think the efficacy is beyond 60 or 50% clear. This is the study that we conducted at LV Prasad Institute. This is extended depth of focus contact lens. And in terms of axial length, we found that 59% efficacy in myopia control in Indian children. Now we know that the peripheral refraction counteracting the peripheral defocus is the phenomena that's happening right now. Based on that, I think things are going to change in the myopia practice. Previously, we were using only on-axis refraction. Currently, people are looking at assessing the refraction in the periphery of the eye. This is open field autorefractor. I think future we are looking at much more evolved technology. This is something that we developed that you can use over retinoscope to get peripheral refraction. I know Dr. Jatani has also developed a technology to determine the peripheral refraction in routine clinical setting. So I think this is evolving and people are now looking at peripheral refraction in the clinics. The other thing that I want to highlight is, we have these various myopia control options. One of the common questions people ask is, when do we start? When do we stop? Whom should be given a treatment? So I thought I will quickly highlight the impact myopia guidelines. Again, various ophthalmologists across India, including Dr. Jatani is here, was part of this. IMPACT, this is already published in IJO in 2023. First thing in myopia management, I think, is to identify true axial myope. Just because somebody has -7 or -8 at the age of 7 or 8 does not mean this is an axial myope. There's abundant cases of keratoconus. It could be mere steeper cornea. So it's important to rule out refractive versus axial myopes. And these days, we're also looking at a lot of pseudomyopes. Again, just because somebody has minus power does not mean this is an axial myope. Then, given that myopia is multifactorial, I think it's important to map the risk factors, whatever you can in a routine clinic. It could be asking time outdoor, it could be looking at accommodation, it could be looking at axial length, looking at the periphery of the eye if you can. Whatever is possible in the clinic, I think we should look at, but clearly beyond assessing the central vision and central refraction. Again, taking an example of 7-year-old -7, do we prescribe myopia control lens there? 7-year-old -7 could have been stable since the age of 1. It could be 13 years -7 now, but maybe myopia is stable since 5 years. In these cases, I don't think there is any necessity for us to pick up or to start myopia management. It's important to pick a progressive myope. Only 17 to 20% of children in India are progressive, which means 80% do not need a necessary treatment. Given that multiple treatment options are available, it's important that we hit the target appropriately, provide appropriate myopia management. I always take a referral to playing like a chess. You don't want to play everywhere. You want to see what's really happening on the ground, what could be the risk factor, and accordingly counter it. Is you want to target accommodation, you want to target the foria, you want to look at peripheral defocus. I think you want to look at times, lifestyle modification will do a fantastic job. So it's important to look at what could be really triggering. In myopia management, it's important to consult regularly. I prefer seeing patients 4 to 6 monthly, and the myopia management guidelines that we developed also indicated 4 to 6 monthly follow-up, because you can pick up a progressive myope easily. You can combine treatment wherever required. And people also ask, okay, when do we stop treatment now? You started on atropine, you started on bifocal or defocus lens. When do you stop? Refractive surgeons consider operating, refractive surgery after 20 years or late teenage, after that 20 years. I think considering the stability of the eyeball, stability of the growth, same analogy can be applied to myopia management as well. So we are looking at late teenage, cessation, after tapering the treatment, especially if you're on pharmacological management or when with optical, given the rebound phenomenon. So late teenage, taper, and then stop. So this is the diagram that I want to emphasize that all the treatment strategies work. There is nothing like, high dose atropine, yes, on the top, but given its side effects, low dose atropine, great. Multifocal contact lens, defocus spectacle. I think there is efficacy for various myopia control strategies, but pick your treatment wisely. I just want to highlight one case before I close. This is the case that I've seen in 2021. You see that in 1 year on myopia control lens, contact lens, the changes were 0.08 millimeter in right eye, 0.02 in the left eye. Patient did not use the treatment for 4 months, and then they came back, boom, there is a clear increase in axial length, 0.14 and 0.10. Whatever changes we saw in 1 year, it's more than that in just 4 months. So there is a rebound with optical treatment also, not just pharmacological. Then it can be mitigated. Once you see the treatment, once there is a clear rebound, you can always put them on myopia control. We went with peripheral defocus spectacle here. And again, we got the myopia back in control. So I think I want to highlight that rebound with the previous case. But myopia control with optical, I think it's hitting too many things with one shot. We learned, or we know the philosophy that one shot you can hit two birds, the best case. But I think with the myopia management, using the optical strategies, I think you're hitting multiple entities in one shot. Namely, you're looking at correction. Clearly, you want to prescribe something to see clearly. You're looking at controlling the progression. With the spectacle, the compliance is better because they have to wear it to see things. So they will have myopia control always. There are more wearing hours. I think with spectacle mode or contact lens, if you give something in that fashion in one shot, the consciousness, the emotional stress, the awareness for the parents that my child is on some treatment, I think will be minimized. So that's an advantage. And yes, the complications compared to the other aspects, I think in optical strategy is relatively less or none. And people may ask, yes, all the C's are great, but what about the costs? I think that's a challenge right now. I agree to that. But bifocal, whoever can afford, I think this can be a best bet. So to conclude, I want to emphasize that myopia management is beyond mere single vision prescription. Various optical strategies do exist, all the way from bifocal to the latest contact lens and the spectacles that we already spoke about. There is efficacy, there is awareness, there is evidence to say that all these strategies do work for myopia control. Do not shoot in the dark. Do not stop abruptly. There is a rebound even with the optical strategies. One shot, if you can do multiple things, keeping cost and the perception of the patient in mind, I think there are multiple advantages with the optical correction. With this, I thank you for your attention and happy to take any questions at a later stage. Over to you, Dr. Roshi. Thank you.
Thank you, Dr. Pawan. Thanks a lot. One main take-home message is not all myopias need treatment. And I think we are holding this webinar for the benefit for a lot of general ophthalmologists. So if time permits, Dr. Pawan, I would request you to, highlight what is peripheral refraction, what is accommodation lag, and what is for effect on phoreas. Maybe for the better understanding of the general crowd to know when to prescribe a optical versus an atropine drops. Okay, so we can do this at the end of all the 4 talks. So quickly going forward to our next speaker, who is the Rajnikant of myopia here. Yes, that's Dr. Jethani, and I call him Rajnikant because we didn't even know the word atropine when Dr. Jethani had actually started using. I remember sir had started getting 1% atropine vials and started diluting them in his own clinic and started dispensing. I think he has more than 15 years experience in dispensing atropine drops. Sir is a prolific researcher, even in a private practice, and kudos to all his effort in educating so many students, educating all of us here in India. The pediatric ophthalmologists are so thankful to Sir for creating so much awareness. And Dr. Jithani will be talking on combination therapy of low-dose atropine and opticals. Over to you, sir.
Thank you so much. Okay. Thanks, Roshni. Thanks for a wonderful introduction. And I think I would like to thank Dr. Vardhaman, MOSCON for the opportunity. My task is actually a little bit easy, and it is cut out because I have previous nice speakers, good talks on atropine and on glasses, which Pawan has already shown. I'll just quickly summarize the facts, and then we will move on to combination therapy, because bulk of my work in combination therapy is with glasses and atropine. And there were some of the slides which will be a overlap with Shruti, who has shown a few slides on combination, and some of the slides will be similar to Dr. Pawan's slide. So these are, at this point of time, whatever work we are doing, these are the recommendations in the literature on pre-myopes who are non-progressors, pre-myopes who are progressors, myopes who are progressors. So myopes who are progressors, we have to do peripheral refraction accommodation lag. And these two things will basically tell us what is to be done. Behavioral modification goes without any doubt. Behavioral modification is the key to reducing the progression of myopia. And then we have two interventions, that is low dose atropine and myopia control glasses. Why myopia progresses? We had an elaborate ideas on how and why myopia progresses. This is where it all started. The reason why I put this slide was because you see that this was a randomized double mass placebo controlled study. This was a very good, very standard, very powerful study, ATOM 1 study. They had randomized the eyes. So one eye was getting atropine 1%. And this was I think one of the last reports on the 2-year report from LAMP, which is now currently the standard for prescribing low dose atropine, where we found that 0.05% is better than 0.01%. And talking about glasses, we also heard Dr. Shruti had her few slides on this, and Pawan spoke on how these glasses work, relative peripheral hyperopic defocus. What it is basically the amount of hyperopia which is more than what is in the center. And great work from Earl Smith III, who has published multiple articles, and he has shown how optical defocus affects refractive development. But most of this work is on infant macaque monkeys. And then this is the conclusion from his own article in 2010. So what is combination therapy? Basically, very easily put, it is atropine eye drops with defocused lenses working together. So the first and foremost question is whether they are safe. What is the theory? How do they work? What is the efficacy? What is the advantage? And where do we use them? So safety, there have been, sorry. I think we have, yeah. So safety, there was a very good article published in 2022 where they actually, this was one of the first studies which presented that it can be used together. More importantly, the considerations that, when the pupil is dilated, whether you can actually use a defocus lens, which is having a central 9mm zone. So whether it is safe or not, they did the first study, Kaimak et al., they showed that DIMS lenses can be added, and they did not really study the efficacy, but they actually studied whether it is safe to use them together. And then there was Newsy et al. This was in PLOS 1. They showed good results with combination therapy in European eyes. We presented our data in last year AIS conference and then published it in IGO, where we actually tried to show that bulk of our patients were actually non-responders to atropine. So they were actually responding to atropine, but not as much as we would like them to. And so it was added. So it was not that we removed atropine, but we added so it was more of a supplementary therapy. And the theory, obviously, this is the theory. We all know that both the mechanisms both the things are working at a different mechanism. Whereas atropine is playing with the dopamine concentration, and optical glasses are playing with the optical defocus, and they are making it more myopic defocus. So both the ways are different to each other, and so they should be complementary to each other rather than stopping from each other. This was study in 2023. They clearly showed that when you offer DIMS, which is defocus incorporated myopic multiple segments, when you offer this with atropine, this was more stronger than a single therapy. And this was the slide is from the presentation at AIOS. We showed that pre-atropine, you can see that pre-atropine progression was minus 0.76. This is over a period of per year. Then pre-DIMS, which means that atropine has been given. So the progression has reduced to 0.68 diopters, but it is not under the point of 0.5 diopters, which we take it as the reduction in progression, or we call them as responders. Post-DIMS progression, when both the things were working together, it came down to 0.24, but still there were two patients who still progressed by 0.57. Taking these two along with the mean progression becomes of the 10 children becomes minus 0.39. So what we are showing is a progression of the 8 children. So DIMS and atropine does help, but still there are patients who do progress, and the classical definition would still keep them as non-responders even when we are using both of them together. This is our data of almost 2.5 years, where we have worked on non-responders to atropine, DIMS, and HALT lenses. Both of them are from standard companies, and both of them work fine. Follow-up is almost 18 months in both the groups, and we found that both of them work nicely. HALT may be 0.02 diopter more, but that is not very significant when we do a statistical calculation. So both of them do work nicely. We can always use atropine first, and then introduce these glasses if at all they are not responding to atropine. Advantage is that defocus lenses like HALT, DIMS, or Zeiss MyoVision Pro will be working on peripheral refraction, whereas low concentration atropine is working on some other pathway like dopamine, on the release of dopamine. So the effect is independent of each other, and therefore it is complementary to each other. Where to use it together, whether together is better than, we should use it as a primary therapy. Whether we should use combination therapy as a primary therapy, or we should use it or restrict it to atropine non-responders. Now, considering India as a price-sensitive country, bulk of us at this point of time are still prescribing atropine as a primary therapy. And then we start with glasses. We can start with glasses if children are very young, and they are not really, the parents are afraid, or we are afraid that, we are introducing atropine at a very young age and compliance may be poor. We can add glasses, and then later on, if they're still progressing, we can add atropine when they are pre-pivotal, or when we feel that, the myopia progression will be soon be coming or jacking in the axial progression. So pre-myopes, maybe we can start with atropine, or maybe we can start with glasses and then think of combination therapy. So that's all from my side on atropine and glasses. Thank you so much. Thank you for the opportunity.
Thank you, sir, for such a crisp discussion. So I think what Dr. Jethani essentially is trying to say is the mechanism of action of low-dose atropine and that of DIMS are mutually exclusive. And like any other disease, like an infection or a diabetes, where two drugs can be added if they have two different mechanism of actions to give a summative effect and better control. I think that's what we are looking at in combination therapy, since both the interventions are mutually exclusive of their effect. So great. Now, since we have covered a lot of theory topics and validated the effectiveness of the treatment protocol, coming to the most practical aspect of today's webinar is in standalone private clinics, how do we set up a myopia clinic, knowing, after the information that we have gathered, how do we convert it into clinical practice practically? So let me introduce my very, very dear friend, Prachi. Thank you, Prachi, for accepting the invite on such a short notice. Dr. Prachi is again a long-term pediatric ophthalmology fellow from Arvind Eye Hospital, and Dr. Prachi works both in charitable and private setup in Mumbai and has immense experience in dealing with patients of all economic strata. And I request Prachi, to take us forward to guide us. How do we set up a myopia clinic in private practice?
Thank you, Roshni. Thank you, Vardhaman, for having me here. So let me see if I can give some guidance and we can have a discussion about how we can set up a myopia clinic in our private practice. So can my screen be seen and can I be heard well?
Yes, absolutely, Prachi.
Okay. So starting with, do we need really a separate formal name for the myopia clinic? Well, so there could be some benefits to a practitioner. We can have some streamlining of patients. Our intent is made very clear, is more clearer to the parents when we have this kind of a name to the practice. It's easier on the system because the staff is attuned to attending to the patients and working them up in that order. Also, in the waiting area, the parents can really interact with each other and try to share their stories with each other. For the practitioner, group counseling can be done. So, as we know in myopia, a lot of chair time is required. So, the counseling regarding the common factors about lifestyle modifications, etc., can be done all together. It does give a sense of belonging. And also, in the typical Indian sense, it gives a sense of competition with actually the parents and the kids actually discussing with each other about how their powers are stable or how their powers are increasing, etc. So all in all, this acts as an excellent marketing strategy. Also, it helps in creating awareness about the condition and from mouth to mouth publicity, increasing the practice in turn. So when would be the right time to start a myopia clinic? So probably when 10% of our daily OPD has children with myopia, it may be a good time to seriously think of setting up the clinic or at least start advocating about it. Now, simple advocating tips I would like to share. So, how do you advocate about it? You can simply put up some posters in your waiting area. You can use the print media to give some excerpts. You can put on informative videos in the waiting area. You can use radios to give certain interviews and spread the awareness. The social media handles, the Facebook, Instagram, very, very important. You can put up some videos, some reels, and create awareness regarding the condition, regarding the treatment. So I think this then becomes very amenable to the parents to understand sometimes what you have discussed in clinic, and when they just go back and look up about it. I have just put up this slide because this is from the BHVI, that's the Brian Holden Vision Institute. So many a times they have this really downloadable, infographics which you can just download and print for free, and which you can just put up in the clinic very easily without you having to take the efforts to make it yourselves. Also, we learned about the peripheral defocus glasses. So the companies that deal with it, they are also interested in marketing their product, and they help in turn to set up the myopia clinic. So they would actually put up a wall regarding these glasses, regarding the treatment, and put up something like a myopia corner if it's a very big setup. If the setup is small, even a small poster like this is good enough to, kind of make the parents inquisitive about it and come up and ask up to you as to what this treatment is or what these glasses are. So all of this helps in the marketing in a big way. Another way of advocating it is to go into the community, hold eye screening camps either in the neighborhood or in the school to try and identify myopes and get them. And at the same time, in those places, you can have a lecture talking about what is myopia, why it is important to detect it and treat it, etc. So which patients do we enroll in a myopia clinic? So all your patients who are on regular treatment and are following up regularly with you, newly diagnosed myopes, kids with positive parental history of myopia, siblings of myopic kids to try and identify them in the pre-myopic stage. So the flow of work is such that we profile the patient, we work up the patient, and then we take them up for counseling. So what does profiling mean? Is basically a myopia workup sheet where a detailed history is taken about what glasses they have been wearing, what was the apparent age of onset of myopia, and the current refraction. The family history as to maternal, paternal side, how much of the strong history of myopia is there, because as we know, when there's a positive family history, the risk of progression is higher. And important lifestyle conditions, what's the time spent outdoors on weekdays, weekends, same for near work, what is the viewing distance, what is the gadget time. So all of this is recorded in a sheet. Then we move on to the actual workup, which comprises of this. So cycloplegic refraction, all the previous papers have emphasized the importance of using this for diagnosing myopia at the primary setup as well as for progression. The orthoptic workup includes measuring the binocular vision and stereopsis. So accommodation assessment is one important factor that I would like to stress. So we need to look at the near point of accommodation, and a dynamic retinoscopy should be done to look for an accommodation lag, because these are the patients in whom if you give atropine drops, they may have near vision issues. They may sometimes develop esophoria. And these are the patients in whom we can use progressive addition lenses as told by Dr. Pavan. Now, peripheral refraction. Now, this is something which we are doing as an added testing in the clinic. And a proper machine is sometimes not really affordable in small private setups. So we can use the peripheral retinoscopy. So this is what Dr. Pavan has shown. So this is actually published by him only. So this is a very simple device which is put up in the trial frame itself. There are those red LED papers that are there, which is this central slot is for the central refraction, while these at the side are for the peripheral refraction at eccentricities of around 22 degrees. So all you need to do is put up the proper refraction of the patient in place, and over it in a dark room, you just use your retinoscope to just see the reflex in the center as well as the periphery, and then determine the peripheral hyperopia. Another way of doing it is by making the child fix at distance. So I acknowledge Dr. Pooja for sharing this video with me. So here you just do again the retinoscopy in the primary position at nasal and temporal eccentricities. We see these vision charts that are being put up, and the child is asked to fix at those charts, and then a peripheral retinoscopy is performed. So these are the two practical ways of doing it. Dr. Jitendra has also established another method of putting an extension to the retinoscope itself and putting targets on that to estimate the peripheral retinoscope. So in this method, there is a ready retina table where you decide at what distance from the central vision chart you want to put the targets to estimate the peripheral hyperopia. So any hyperopia of more than plus 0.75 is considered to be significant, and these may be good candidates for starting defocus glasses. And obviously, you have to have the HL length measurement and keratometry using an optical biometer every 6 monthly to yearly, which will also tell you whether the myopia is under control and whether your treatment is working or not. So once you have all of this information in place, we go on to the counseling part, which is very important. A lot of chair time is required with the parents. A PowerPoint presentation is a good idea to discuss the pros and cons of therapy in detail. You have to be realistic and tell them the success rate of the glasses and drops. And the importance of lifestyle modifications has to be stressed on at every single visit. This is a myopia calculator, which is again a ready thing which is available on the BHVI, the Brian Holden Vision Institute website. All you need to do is just put up the child's details, and it's a good way of showing the parents that how the treatment can make a difference in controlling the myopia, which just helps them convince them better. The value-added services for the clinic can be you set a particular day or days for the clinic when the parents also know that this is the time that the patients are going to be looked after, and you can offer some discounts for the same. Distribute pamphlets or circulate videos for information about the condition. You can make customized myopia booklets, which was a brainchild of Dr. Shruti. And you can also update the peripheral defocus glasses booklet. So when these special glasses are given, they come with a booklet, and you can enter your refraction at every visit in that also. You can distribute toys that can be played outdoors just to emphasize your point of the child to spend time outdoors. You can have a trained optometrist or counselor to help you with the data collection and also introducing the topic. Ensure to enter a follow-up date and do send reminders for the same. It is highly appreciated by the parents. You can group the patients in a separate Excel so as for you to actually just look up at your own data. Create a WhatsApp group of these parents and you can send regular updates or offers on the group. So just to summarize, first identify the potential to set up a clinic. If not, you can just individually start practicing. There's nothing wrong in that. But do advocate and market about the facility. Try and assign fixed days for the clinic with extra perks for it. Have designated staff as one point contact to clear doubts real time. Identify, enroll, work up, and do a detailed counseling. And ensure to mention a follow up date and send regular reminders. Thank you.
Thank you, Dr. Prachi. What an excellent presentation on how to practically implement the concept of myopia clinic in private practice. At this point, I would also like to thank and at the same time introduce our panelists for this session. Our panelists have been patiently listening to all the speakers. And so our first panelist tonight is Dr. Sumita Agarkar. Madam is the head of department at the Temple of the Eye Shankar Netralaya. She is my mentor and she's the reason why I am here today talking with all of you. Of course, ma'am, I remember 12 years back you asked me questions to enter fellowship and today it's my time to ask you a question. And ma'am, so I would like to know that since Shankar Netralaya is such an apex institute, what is the actual protocol that is followed for walk-in patients with new myopes or myopia follow-ups? That what is done practically in a state-of-the-art center like Shankar Netralaya?
First of all, thank you for inviting me to be part of this panel. There are really serious researchers here, and I continue to be a clinician mostly. But for new myopes, we actually do not start any myopia control methods at the first. I think vision comes first, and you should really first focus on getting the vision right, and then only worry about myopia control. So at first outset, we do a cycloplegic refraction. We give glasses, but we also do a baseline myopia evaluation, which is we check axis length, a detailed biometry actually with a optical biometer. We do peripheral refraction in patients who cooperate. We don't do lack of accommodation sometimes in the first visit, but we do a detailed history and documentation of their outdoor time and their gadget time and all. And I think the first thing only we talk about is lifestyle modifications and a spectacle prescription in the first visit. We usually don't, even if there is a family history of parental myopia, even if there is a sibling who is myopic, I don't start myopia management in the first. Because we have to remember that we are not treating myopia, we are treating myopia progression. So unless there is a documented progression, I do not see any reason for us to jump in and start with the myopia management strategies in the first visit. Now, this is for the newly diagnosed myopes. For those who are already wearing glasses and are showing progression, our cutoff for starting management is standard, which is 0.05 diopter over a period of say 6 months. Anything more, we do look at and also we document again axis length in every visit. So depending on parental myopia and all, my threshold for intervening is probably lower in patients who are already myopic or progressing more than that, or have both parents who are myopic or who are younger or started with a higher myopia. Those I probably may start, my threshold for starting a management strategy is lower. But those who are progressing less than that, I usually continue with lifestyle modification and documentation in each visit. We do peripheral refraction using the machine we have open field autoref, so we do document it.
We're not able to hear you, ma'am. Is there some problem in the connection?
Yeah. Little bit here and there can be. We have to also remember that sometimes it's easier for me to say no intervention. And I was just talking to Meenakshi, who was my colleague, and she said she talks about lifestyle modification, and patients tell her, "Oh, you don't know about the new glasses which have come." So, so there are all types there, and you have to probably you have to talk. You have to kind of customize your talk depending on who is your patient. I hope that answers your question.
Well, I think the most important thing we need to listen here is we are not treating myopia, we are treating myopia progression. I think that is one thing we all really need to remember. That, like glaucoma, we are not going to reverse the myopia that has occurred, but we are going to halt the progression. And until and unless we document the progression, the treatment may not be warranted. So thank you, ma'am, for saying that so confidently in the position of authority. Thank you. Coming to our next panelist, Dr. Siddharth, again, a very close friend, colleague, of course, a senior mentor. Dr. Siddharth is the founder of the Childcare Center at LV Prasad Bhubaneswar and has an august patient load of at least 2 to 3 hours waiting, even in a private practice. So congratulations, sir, for bringing so much awareness in a city like Mumbai for pediatric ophthalmology. And what I need to ask you today is, for the benefit of the general ophthalmologist and the students listening to this webinar, is most speakers have spoken about pre-myopes, and we need a definition of what is pre-myopia. Basically, what we understood was that the emetropization is a natural progression of hyperopia regression. And then when there is a pathological event, it goes to myopization. So how do we differentiate these two physiological and pathological processes? And how do we identify a pre-myope? And what do we do for their treatment?
Thank you, Roshni, for that very generous introduction. A long waiting list just shows my inefficiency and not my popularity. But your question is very loaded, and I'm going to take a little more time to elaborate on that. Let me play the devil's advocate. What do we understand about myopia till now is very little. What we don't understand about myopia is very large. Now, we are trying to define a category of people whom we want to start prophylactic treatment so that they don't become myopes. The whole idea of myopia control is to prevent the complications of myopia, right? So there the concept of the number needed to treat comes. If you start defining pre-myopia as anybody who does not have myopia and is at the risk of getting myopia, you will have a very large number of children who fall in that category. So you drop that down into people who are more likely to get, for example, people whose parents have myopia. So that will narrow it down further. If one parent has myopia versus two parents has myopia, you will have a shorter subset, plus the particular axial length or refractive error at a particular age group. Now, emetropization is both active and passive. So when you are born, your eyes are small, and any which ways, as your entire body grows, your eyeball is also going to grow. That is going to cause increase in axial length, flattening of the cornea, and the flattening of the lens or the thinning of the lens. That is a passive process. Now that process can be influenced by the active process, which is the visual stimulus. So emetropization is both passive and active, where the passive part is much more important than the active part. That's why most children will emetropize and some children will not emetropize. Now, what is myopization? At a point where emetropization is complete, further growth of axial length should stop, but it continues. Now, again, the biggest determinant factor there also is genes. So some children are passively prone for increased axial length, irrespective of what they are seeing. And that is the passive progression of emetropization into myopia. Yes, children who have parents who have myopia have that gene. And if they have the adequate amount of stimulus to trigger an increased rate of progression, they will probably start the myopia earlier, progress faster, and end up with a higher number. So when you want to define pre-myopia, you want to target this small subset, which is really very small. So the definition should be that if both parents have myopia, and if the rate of loss of emetropization or the less of loss of hypermetropia is much faster than a comparable people of the same age group. Now, again, even if you look at the incidence of myopia in children whose parents have myopia, if one parent has myopia, only 10% of their children will have myopia. If you have both parents as myopia, then that increases to 40%. So should we include children whose one parent is myope, or should we take only children whose both parents are myope? I'm trying to say, what is the problem with defining pre-myopia? Because you do not want to start a prophylactic treatment which you don't know when you can stop. It is not like a vaccine that you give and then it is over. You are going to start a treatment, and in absence of any guidance, you don't know when it will stop. What are the instruments of giving any prophylaxis here? Only pharmacological you can give. You are not going to tell them you start wearing contact lenses to prevent myopia, because that is what they want to prevent. Now, if you are going to start a drug, you should know when to stop it. Unfortunately, with atropine, we don't know when to stop. Rebound phenomenon is very well documented. Rebound phenomenon with all the concentrations is documented. And now with the Atlas study, which is the latest study from the Atom group, rebound phenomenon has been documented even into third decade of life. So you might feel that 18 years of age, you have stopped now the growth is over, and now if you stop the drop, it is not going to progress. The analogy which is used by refractive surgeons, that after 1918, probably the growth will not happen. The problem here is the moment you stop atropine, after a few months or years, regression starts. You will be surprised to know that when the Atom 1 and Atom 2 children were followed up after 15 and 10 years respectively, they have found that there is no difference between them and the placebo group now. That means the rebound phenomenon progressed into the late 30s. So the problem with any pharmacological intervention to prevent myopia is you simply don't know when to stop it. So that is my point. The problem with atropine is you know roughly now when to start, you know roughly how it works, but you also know the moment you stop, all myopia is going to come back. So are you just postponing the inevitable? Or maybe that ultimate final outcome is determined by genes, and your atropine is not going to control the gene? So it's a big question. So if you start treating children, and even before they have myopia, your number needed to treat to prevent one complication of myopia will be massive. You will not be able to control myopia, because if he's destined to get myopia, he will get myopia. And you will end up giving so much of drugs to so many children to prevent that one incidence of retinal detachment, which would probably never happen. That is the problem with defining and treating pre-myopia. I hope I am clear, or I have confused you more.
Sir, actually, I am so clear in that thought. This is just because a lot of young practitioners succumb to the pressure of the parents when the older sibling has myopia and is on atropine drops, and they are like, can we start this for the younger sibling also? So it is just a reminder for us clinical practitioners that we know science and we should not succumb to any kind of intervention which can cause long-term side effect. That might not be true for glasses, but for atropine definitely, because we are instilling something into the eye. So if they like pressurize us for like a defocus glasses, okay, you can say fine. But if they pressurize us for like we can start drops, we should be firm and just say no. That's what I wanted to hear from you, and that's what. So yes, pre-myope is a very. We have a lot to research in that. So Shruti, Pavan, Jethani sir, like keep the research going on and give us more insight maybe a few years later. So introducing the next two panelists. They are, I think, best friends, and they are like the torchbearers of MOSCON, Dr. Vaishali Une and Dr. Naina Podar. The main reason for inviting them as panelists was that Vaishali ma'am and Naina ma'am work in high volume government setup hospitals. Dr. Vaishali Une is a professor at Aurangabad Medical College, and Dr. Naina Podar is the head of department at Nair Hospital. And so my question is targeted at this mass practice. That Dr. Vaishali, first for you, what challenges do you face in counseling and giving intervention for patients of myopia progression in the kind of setup that you work in, and what measures do you take in tackling these obstacles?
Yeah. Thank you, Dr. Roshni. And before I answer your question, I would like to congratulate you and MOSCON for having such a wonderful team, and we had such wonderful speakers, and it really gave insight to so many different problems. I was very happy when I was included in the first, when there was a consensus of childhood myopia. So from that, and at the WSPUS at Hyderabad. That time we were all very taken aback by the Singapore study. So I had my own research work at from 2018 to 19. But then again, the main drawback when COVID came. So out of my 30 patients after COVID, the follow-up only 7 came up. So the main thing is the follow-up, the challenge, biggest challenge which we face in high volume this. And again, like the previous speakers have spoken up. So counseling is very much needed, which we as teachers in government medical colleges, we are unable, or we can't spare that much time or that much, so much of telling what it is needed. Because as Sumati ma'am has rightly said, that it is about myopia progression. And so many others, like so many of our ophthalmologists also feel that, okay, once you diagnose myopia, we have like blindly it has been started. So the flip side is, con side is, I would say that at least we are working with the residents. So we know that the residents know what it is to be done. So we go on teaching about the retinoscopy, which was so much done in our times as a resident, but nowadays it is just left to the autoref and this. So we try to teach the residents about the retinoscopy, teach them about the myopia, the progression. So there is both pros and cons. So again, secondly, the biggest challenge is also about the cost. So now we have 2 speakers advocating about, or rather all of them advocated about the combination therapy. So we are just only on working on the pharmacological part, but the glasses are the patients who come to us from a different background. So it is really a big challenge. The cost is a biggest challenge. So we can't advise them about the defocus glasses, though we of course tell this about lifestyle modifications and the glasses. And after doing follow-up, like mostly after 6 months to 1 year, they will come, but then again they are lost to follow. So that is the biggest challenge. Like you start, you are motivated, you know you have caught them, you know these are the ones who are progressing, and then suddenly the follow-up is not that much. So I would say, just sum up, like the cost is a major factor, then the follow-up and counseling part is a bit difficult in those parents whom we really need to tell them and teach them. And of course, the screen time, that is a major, I'm sure we all face it. So it's so common for parents to give the mobile, and just even for children less than 1 year also. Those who come for ROP screening also, it's so common practice. So that becomes really a major issue. So lifestyle modification and myopia drops is what we are commonly our main forte.
Yes, ma'am. And I think that these two are the main things that have at least proved some benefit, and maybe it's a cost-effective method of halting the pandemic. And for you, Dr. Naina Podar, ma'am, since you are sitting at the position of power of head of department at Nair Hospital, which also now has a special institute for children, and we have a great network of hospitals here. as a parent, I believe that it takes a village to raise a child, which means if we want to bring about a change in the child, we need to change that village. By village in today's times, I mean that the classrooms and the academic pressure that the kids are living in these days, I don't think they make any of these interventions. These interventions won't work if the environment of the child is not changed. Like in metropolitan cities like Mumbai, I don't see a 0 to 8 year, which is a critical period of growth, child spending even that half an hour outdoors on a daily basis. So, ma'am, do you think that we as a group of specialists should, appeal for some sort of change in the environment in which these children exist? You think that will help us bring some sort of halt in this pandemic by 2050? Ma'am, you're not audible, ma'am.
Yeah, thank you, Roshni. Yes, we can definitely bring about the change, be the change and see the change. Firstly, let me thank you and congratulate you for the excellent webinar and the excellent topics. It will benefit even the students and all the general practitioners. Now, coming to your question, looking at the present scenario, you see that the classrooms are so small, tiny, not ventilated, they are AC and crowded also. So the students, they do not get to move outdoors, and the teachers do not emphasize, especially in metros like Mumbai, there is very less space for the kids. I'm talking about the smaller kids. They have very less space to move around, play around. So they are stuck up there. And secondly, with the current scenario, we cannot ask them to go for a digital detox. Earlier, what we had, the gurukuls under the tree, I think if we can revert back to that system, there's nothing like it. Open air, under the tree, with adequate sunlight and studies. I wish we can do that. Secondly, I feel that we have to sensitize our students, the postgraduate students. Not only that, but I feel we should sensitize our undergraduate students, which is a larger chunk. In their curriculum, especially in ophthalmology, we should include this myopia progression, at least a paragraph. I would like to tell the Board of Studies to include this. Okay, that is another thing. Thirdly, what we can do is sensitize the parents, whoever who come to the general ophthalmologist. Keep a poster, as Dr. Prachi was telling. You can have a poster somewhere, and that will trigger some reaction, some action, some inquisitiveness. So thereby we can sensitize the parents. And finally, I feel we can go ahead the way we did for organ donation, eye donation, the awareness. Similarly, if we can do on social media, in the newspapers regarding this myopia progression and the benefit of outdoor activities, lifestyle modification, that will bring about a great change. Thank you.
Thank you, ma'am. I hope we can take this forward in a big way, and for that we would need help of our MOSCON leaders, Dr. Santosh and Dr. Vardhaman and Dr. Aditi. Because I hope this webinar has at least made each one of us realize the magnitude of the issue and the possibility of halting it by just small measures which can be introduced. And we just hope that by 2050 we are not where we had predicted to be. Just would like to ask if there is time for more questions for the speakers, or are we running out of time?
I think one or two questions we can take.
Yes, Dr. Vaishali wants to.
I just want you to highlight that, like we have always, since medical student days, we know the judicious use of steroids or judicious. So similarly, like as we are in the social media and as we are also promote advertising about the myopia, but we should also make a fine statement should be there about judicious use of atropine. It shouldn't be that, okay, like ma'am said, just diagnose a patient of myopia and start atropine. So that should not happen. So that fine, I think it is a star you should put up that not all kids with myopia should be on atropine? Thank you.
Yeah, I think that was a question I was going to ask Dr. Jethani, since he has a maximum experience with atropine here. For the benefit of our audience, in the short span of chair time that they spend with the patient, what is the thing that they should look for and counsel while prescribing 0.01% atropine?
I think first of, I would repeat most of the things which I would be saying would be a repetition of what Dr. Sumita ma'am said. First and foremost thing is that we are not treating myopia. Myopia is being, and I keep repeating in my talks that myopia is being treated since years altogether. So we are trying to treat, or rather we are trying to slow down the progression of myopia, as Siddharth rightly pointed out. Atropine, one good point of the ACTA study is that, after at least 20-25 years, we have now known that at least atropine is safe. Over a period of, they have used atropine, there is a rebound factor, but it is safe, and there have not been any positive or negative side effects noted of atropine. So practically what ATLAS study has shown is that it came down to nil. And when you talk with the authors or when you read the study, and I'm sure Siddharth must have put in a lot of effort in reading the study, because I know he does that. So if you see that, bulk of the data is missing, there are a lot of patients who were on drops were missing. And so I take this opportunity to say that particular study doesn't have all the patients who were not followed up. There were only part of the patients who were followed up. So we don't know the whole story. Now, coming back to the question that you asked, I would like to see the progression. So when the patient first comes, we document myopia, we give glasses, we see whether vision has improved or not. And we do a baseline axial length, we do a baseline keratometry, and we just want to see over a period of time whether he or she is progressing or not. If there is progression, then we would like to see the accommodative lag. But irrespective of accommodative lag, it is India is a cost-driven country. So irrespective of that, if there is a progression, we would like to start atropine 0.01%. If that answers the question.
So my main intention of this question was, are there any serious contraindications for giving atropine?
No, with 0.01%, whatever we have followed up in last 8 to 10 years, we have not seen, apart from allergy, we have not really seen patients going into esophoria. There were 3 case series by Mihir and his group. And there have been some patients who complain of allergy, but we don't know till we start. We don't know whether they will be allergic to atropine.
So in atopic patients, like who have history of atopy, because there can be overlaps, right? Like in allergic conjunctivitis, they do develop a progression of myopia by whatever rubbing, corneal. People don't document axial length. So it might just go off as a progression of myopia in a very like a primary setting. So is allergic atopy or allergic conjunctivitis a contraindication for starting?
Not directly, but yes, a relative contraindication. These patients, you will be more closely looking forward that they should not have a complaint. So you would actually, atropine is like giving more chair time to the patient. You sit with them, you discuss all the pros and cons, and you tell the patient, this is what it is. So in early days, we used to sit even longer. And now I think there are a lot of patients in whom we actually are stopping atropine, because they come with atropine and there is no documented progression. So it is more like that now we are actually trying to tell them that there is no progression, there is no need for atropine. It is now it has become a little easier because there is a lot of industry push that each and every myope should be given atropine. Whereas we always reserve that it is only for myopic progression. It is not for myopia. We are not doing anything for myopia. Actually, we are giving glasses. That's it.
So quickly, can you just tell us that how do we taper off the child of atropine, like after 2 years?
So that is, it's good that you asked. There is no, why 2 years? I mean, there is no such study. So why 2 years? That is a very good question. Why 2 years? Now, 2 years is a time which started in Atom 1, which was, I think, published in 2006 or 7 in ophthalmology. So what they did was they did a randomized controlled trial of 400 children. And there they were giving atropine 1% in one eye and placebo in other eye. Now, over a period of 2 years, because of ethical concerns, that they saw that there was a building anisometropia in patients who in eyes which were not on atropine, and so they had to stop the duration was 2 years. And I personally think that has probably stuck. There is no evidence that you should start tapering it at 2 years. Siddharth very validly said that nobody has any idea when to stop atropine. But coming back to the point, how to taper, I think after 2 years, you should start thinking of, you will have to eventually stop it. But sometimes, not sometimes, more often, I do. In our first paper, which was presented in 2018, we actually had presented a 3-year data and not a 2-year classical data. I don't think anybody has done a 3-year trial, but we did a 3-year study. And right now we do follow it up at least till 3 or even 3.5 years, and then we think of tapering, because after 2 years you have to sit with the patient. You have to tell them that in bulk of the world, or most of the world, people have done studies for 2 years, and now it has been 2 years, and you still want to continue? There would be a rebound. So you have to talk with the patient after 2 years that now we are entering a gray zone with terms of evidence-based literature. So tapering, I would start telling them to do it alternate days, and would see the progression. Would again, as I do, I will be measuring the axial length, I will be measuring the K, I will be measuring the myopia. Late rebounds, I have not seen. Early rebounds, yes, but I have not seen patients rebounding after 2.5 years once they have stopped progressing. So I was pretty surprised, as Siddharth mentioned, that in the Atlas trial, eventually, I've read the study. Eventually, they ended up, there was no major significant difference between the patients who were on placebo and who were on atropine.
I think
Okay.
Dr. Sunita ma'am wanted to add a comment, I believe. Yeah.
Wanted to make a comment about the Atlas study. So what Atlas study really proved was that even though it was underpowered, and as Jitendra mentioned, that they did not really examine all the patients who were recruited in that study, but still, I think what it did prove was that there was the rebound is significant, and it kind of creeps in over several years. It's probably not going to happen in 1 year, 2 year, but probably all of them had only 2 years of atropine, all the
Yes.
people. So probably there was a probably slow creep in of
Maybe.
the rebound, number one. Number two, a lot of these children, we are going to start somewhere between age 10 and 12. And then you are going to taper by 14 or 15. And then there are high school years of intense studies, completely indoor activities for somebody who is, say, from 15 to 17. And I think that's where the rebound creeps in a little bit. And at that time, they are not even coming to you for follow-up because they're busy studying.
Just a quick question, ma'am. How many patients you stop atropine after 2 years? Most of them?
I don't, but
that is what was my point. I was trying to make a point that you don't have to remember the 2-year thing because it was published. There were limitations of the study. They had to do it for a finite number of years. They cannot do it for infinite number of years.
Yeah, but our evidence is based on
2 years. Yes.
2-year data only. So you can, if you are looking at safety profile and somebody takes you to court, they say recommendation is only 2 years. Why you
not? I won't say it is a recommendation. It is the published data. Yes.
Yes. So evidence is published data. Yes. I'm not saying. I think we need to create evidence in our own population. Is all I'm saying. So I think we should pull in data on rebound also, whatever it is, honestly reporting the rebound. And I think this is of course anecdotal experience that a lot of time rebound happens later, because by the time you have stopped it, they are somewhere in their 14 or 15 and you don't see them. Sometimes they stop it themselves. And there is still another couple of years of very intense near work involved, at least in India.
Yes, Dr. Shruti wanted to say something.
Yeah. So actually to add, so how I manage this is the kids whom we start early in age, right around 8 years or 6 or 7 years. For them, I usually stop at 2 years and then see how they goes. But usually the older kids whom we start on atropine, by the end of 2 years, they are in 10th or they're in 11th. In those cases, we continue them through their 12th and then stop it after 12th. So ideally, I think how I try to get my way around this is that for younger kids, it's 2 years, taper and stop and see, watch what happens. For older kids, it's all the way up to 12th. There's no stopping in between. There's no point in stopping. The second thing about the Atlas study was, again, it's underpowered. Also, another bias could be that the kids who progressed would have been the ones to come back to the clinic. We really don't know what happened to the kids who didn't come back to the clinic. So maybe they didn't have a visual issue. So we don't know how the study could have gone either way if all the patients had come back to clinic.
They were all in their 30s. They were called back to the clinic. They didn't turn up.
Yeah.
That's all.
Yeah. So, I mean, I'm just saying there could be a small bias. It was a 10 to 20-year-old
Yes.
study. So it was a really long study. But even otherwise, if I had no issues with it, I would have probably not, like, why should I? That kind of
that's the reason
I just want to make a point. Rebound is not only seen with atropine. Rebound is seen with every single method of intervention. It begs to ask the question: are children who get myopia genetically destined to get a particular power? And are you only just pushing it forwards? That is the question that needs to be looked at now. Because I know that Atlas just called back some 40% of the participants, but whatever data is available tells you that the rebound will happen. It is almost a matter of certainty. We just don't know when. And that poses another bigger question, that by 18, 19, now you feel that it has stopped and he undergoes a refractive surgery.
Yeah, I was about to ask.
And then it rebounds.
Then you are on rebound also genetically related.
So rebound has been seen across the board in everybody.
Yeah, but not the same amount. The amplitude is not same. That is what
amplitude depends upon the rate of progression. If the rate of progression is faster, the rebound is faster.
No, this has not been documented that the rate of progression is related with the rebound when it stops.
Yeah.
No, but the rate of arrest of progression is determined by the concentration of atropine. So it is directly showing that if you are slowing it down slowly, then it comes back slowly. And if you are slowing it down rapidly, it comes back rapidly.
That is true, but there are a lot of ifs and buts in that.
Yeah.
Pavan, Shruti, everybody,
I just want
ready?
I just want to highlight that I think
My theory to it is that it's an evolutionary change. You really can't stop it. Our world is limited to now very, very near things. And it's a kind of just like our tails went off, we are going to get glasses. That's all.
Yeah. Can you hear me, Dr. Roshni?
Yes, Pavan, please tell me.
Yeah, I just want to highlight that I think each case is very different. What we see in the research studies is only a mean value. A lot of people are everywhere. And in the real clinical practice, yes, there are, out of 100, you prescribe whatever treatment that we spoke about. There will be few who do not undergo any change. There will be few who do not respond to anything. And there will be few who will be. I think that's where I think close monitoring is the key. For whatever we spoke about, you will have more answers as we evolve, because each case is very different. That will teach us, okay, in 4 months' time, to stop treatment, at times there is no change. It could be sibling also, same genetics, there could be some rapid change. We talk about one treatment, it is multifactorial. So I think the long story short, I want to highlight that each case is very different. Number one size does not fit all, and close monitoring, regular consultation might give us more outcomes.
Yeah, so while you are speaking, Pavan, let me ask you the next question.
I think
yes,
we'll have to probably. It is very interesting discussion, of course, and we would like to learn more. But I think probably we should try and wrap up. But one suggestion or one request I have for all the excellent speakers and panelists, if you could actually jot down for your own talk, maybe a small, like a 4 or 5 key message points, and share it with Roshni. She can compile it together. We can share it with all the members. I think it has been very, very exciting webinar, and we have definitely learned a lot. And of course, as I understand from all this discussion, because me being at core a refractive surgeon, I have seen the aftermath of what happens to these patients later on when they become adults and when they come for refractive surgery. And we have also seen how they come up with their retinal issues and other things. So I think controlling myopia goes a very, very long way. And I think all this combination treatment put together definitely will help us. But I think today, for all the general ophthalmologists, they should definitely get a great bird's eye view about there is not only the atropine which is there today, there are other things, and it's not that you give atropine to everybody. You give in specific indications. It is not that you stick to one, you also try combinations. So there are a lot of take-home messages for everybody. So definitely, I think this is something. I think Roshni, if you could just slightly coordinate and get a nice compilation, like 3-4 points from each speaker, I think that will be absolutely great.
Like a ready reckoner for myopia control.
Yeah,
From the
something like
experts.
very short, like maybe like a 3-minute, 2-minute read or something like that. And so I think before we go further, very quickly, I would like to have comments from Dr. Agarwal sir, then Dr. Atulji and Aditi and Dr. Mandar sir, very quickly in a minute, so that we can go. Thanks. Yeah.
Yeah, it was a wonderful webinar. Actually, we learned a lot of things from today's discussion. And really, myopia was not restricted to spectacle now. So we have to look for many things. It's a multifactorial problem, and we have to deal with it very strategically. And for general ophthalmologist, I think certain things are very important. What I come out with, that is the identification of the myopic patient, means parents as well as the children, then workup of that patient in a particular way, what already has been discussed. You should work up in a very strategical way. Then counseling of patient is very important, means patient means his parents, that is very important. And for treatment purpose, you have to decide which mode of treatment you are opting for, that is very important. And when, how much, when to stop, everything we have to decide. And very important, what Vaishali is also highlighted is follow-up. Follow-up is very important, and for that, I think counseling is equally important. And lastly, the social work about finding those people, training them, that we can hold the camps in schools to find out the myopic children. Then we can call them, we can counsel them, we can work out the strategy for them. And lastly, the awareness among parents and the children at large. So all these strategy we have to imbibe, and we have to implement it in a proper way, so that we can combat this myopia in a very better way. Thank you very much, all the speakers and panelists, for enlightening us for this the problem of myopia. We learned a lot. Thank you so much from MOS side. Thank you.
Yeah, thank you, sir. A quick word from Dr. Atulji. Yeah.
Yeah, thank you. Thank you. It's indeed a very nice webinar. One point which I think most of our members should also learn from this. This is also another source of income. It's a value-added service in your practice. See, it's a big chunk of patients, and you can have some myopia clinic if you set up. If you charge something for the treatment you are going to advise, you do a workup of all those patients. So definitely it's going to add to in their revenue also. Rest all points already presidents and everybody had highlighted out. So it's indeed a good activity, and everyone should think of doing setting a myopia clinic in their chamber. Each and every member can easily do this in a setup. That's what I feel. Thank you very much.
Actually, that was the whole purpose of like setting up this webinar. And I hope that all the members will take advantage of this excellent deliberation. Over to you, Dr. Mandar sir. Yeah.
Yeah, thank you. It was a very informative and wonderful webinar on a very important public health issue that we are all facing, and it is going to increase day by day. And I think the one message which all of us should take is judicious use of the options that are available with us today to treat myopia, including the way we diagnose progression as well, or the way the progression is mapped is also equally important. And it is you can't just label anybody with a little bit of change in refraction as progression. So there is a method in which we go about it. And now with the increasing population, the young population facing this problem, and we know the consequences of this particular issue. I think each and every ophthalmologist has to be aware of the problem. Whether we start a separate myopia clinic or not, we do see children or we do see young adults coming to us with this issue. So thank you very much, Dr. Vardhaman, Dr. Aditi, the entire MOS team, and thank you to all the speakers and all the panelists for enlightening us on this very important issue.
Thank you, sir. So, comment and also official vote of thanks from Aditi.
Yeah, I feel like, as we say, prevention is always better than cure. So I think along with all these treatment strategies and research which is going on for like prevention of the progression of myopia, it is very important that we actually take some efforts in making parents and maybe kids aware of the reasons why this is actually happening, and take some efforts in like making sure that those whatever is in our hand preventive strategies are also given importance along with the actual medical treatment or optical treatment. So I think that is one point I would surely like to stress upon. Obviously, a good chair time is going to give that awareness, but I think follow up of those preventive strategies is also important, is what I feel. Yeah. So I think moving on to the official vote of thanks. On behalf of MOS, I would like to thank our esteemed speakers, Dr. Shruti, Dr. Pavan, Dr. Jitendra Jethani, and Dr. Prachi. Their talks were extremely engaging and informative. Obviously, they had a lot of take-home messages. Thanks to our esteemed panelists, Dr. Sumita Agarkar, Dr. Siddharth Kesarwani, Dr. Une Madam, and Dr. Poddar Madam, for sharing their experiences, which surely enriched our myopia knowledge. Thank you, Dr. Roshni, for moderating the session so well and making it really very lively. I would also like to thank Team Mentor for providing us the platform, and Rahulji for the technical support. I would like to thank all the people attending the webinars on different platforms. And last but not the least, my own team MOS with the main leader, Dr. Santosh Agarwal sir, Dr. Kadhane sir, Dr. Mandar Paranspe sir, and Vardhaman for like making this very nice, interesting webinar happen. So thank you so much, everyone from MOS team, and good night.
Thank you very much, and thank you.
Very nice webinar.
Look forward to the short synopsis if it is possible. I think that will be really
Yes,
nice.
absolutely. They'll be very helpful for everyone.
It's a homework for Roshni.
Yes, yes.
It's my pleasure, my honor, sir. Thank you so much.
Thank you.
Hello,
Thank you so much.
Thank you very much.
Thank you.
Mr. Raulji, we can go offline.
Thank
Yeah.
you. Thank you. Good night.
Yes, thank you.
Thank you. Can we have a photograph